Assalamu alaikum everyone. I hope you're all doing well today. My name is Iman Ahmed. I'm a fourth year medical student at FMH and I serve as the convener at CHSR-FMH. I welcome you all today to today's Journal Club session. CHSR has organized several Journal Club sessions in the past, and this is the first Journal Club session of this year. Previously, we've held Journal Club sessions on topics varying from problems in psychiatry, endocrinology, we're focused on diabetes, and today we are focusing on cardiology. Um, our One of our core team members, Zarhaish, will be presenting today's Journal Club session, after which we will be joined by Dr. Mariam and Dr. Zarrar, who are two very accomplished individuals who will be discussing today's topic. And I hope that all of you have gone through the article. If you haven't, then Zarhaish will be going through all of the important details, the background, the methodology that has been used, and we'll be telling you about the main findings of the article, after which our panelists will be discussing and giving their insights on the topic. So before we begin, I just want to mention that this article is very interesting because it doesn't just use previous data, it uses that data to forecast trends in the future. So we are focusing on trends that will be seen from 2025 to 2050, and that includes prevalence, death, mortality, etc., etc. And we are focusing mainly on Asia because we live in South Asia and we wanted to see how things are here in South Asia in particular, and also how they compare to other regions in Asia. So now I will hand over the floor to Zarhaish, who will be presenting today's article. Go on, Zarhaish.
Assalamu alaikum everyone. I'm Zarhaish Barkatullah, third year MBBS student, and I'm core team member of CHSR at FMH. It is pleasure to be here for today's Journal Club organized by CHSR. Today I will be presenting an important article that forecasts the cardiovascular disease burden and its associated risk factors in Asia from 2025 to 2050, utilizing data from the Global Burden of Disease 2019 study. So GBD study utilizes data from 1990 to 2019 to predict the mortality rate due to cardiovascular disease in future. So it is interesting to know how cardiovascular disease is going to affect us in future. The regions which are being studied in this study are East Asia, South Asia, Southeast Asia, Central Asia, and High Income Asia Pacific region. Our main concern will be South Asia, which includes the Pakistan. So the main points which are being discussed in this article is that the cardiovascular mortality is expected 325 to 2050. And this figure is alarmingly high, and it shows the urgent need for better, better heart disease prevention and care. So the leading cause of death due to cardiovascular disease in future will be ischemic heart disease and stroke, which is being predicted in this article. That's the article that we are going to discuss in this Journal Club. So if we talk about the background of this article, so the cardiovascular diseases are the major contributors to the global mortality and morbidity. In 2019, the cardiovascular disease accounted for nearly 400 million disability adjusted life years globally, with 60% of 18.6 million cardiovascular deaths occurring in Asia. The term disability adjusted life years will be explained in detail under the results section. Despite significant efforts are made to prevent and manage the cardiovascular diseases, but the burden continues to rise, presenting a major public health challenge. If we talk about the methodology of this study, so this study is compliant with the guidelines for accurate and transparent health estimate reporting statement. The estimates of the data used in this article were retrieved from the Global Burden of Disease 2019 study, which is a multinational collaborative study conducted over 204 countries, providing annual data, allowing for comparisons across the years. The study reports mortality estimates from vital regression systems, verbal autopsies, as well as alternative surveillance systems. And the data is generated from the Global Health Data Exchange website. All the causes of the cardiovascular disease that leads to mortality were extracted using the methodology that was consistent with the previous GBD study. So the analysis covered all the major cardiovascular disease causes. For the detail on the causes, you can refer to the article. The link has already been shared in the group. So if we talk about the cardiovascular risk factors, these are defined on the basis of GBD study 2019, and it includes behavioral factors, environmental and metabolic risk factors. If we talk about the statistical analysis which are being used in this article, so they in this study they compared the Poisson regression model with the ARIMA model. Both of these models were trained using data from 1990 to 2009 and projected results for 2010 to 2019. Then these projections were compared with the actual GBD data from 2010 to 2019. The model performance was evaluated using root mean square error and mean error, a metric to assess the accuracy and bias. So what is root mean square error? It provides the single measure how the predicted values deviate from the actual data points. So the less the deviation, the more accurate it will forecast. The mean error calculates the average of the difference between the predicted values and the actual values. So the less the difference will be, the less bias it will be. So the Poisson regression model demonstrated higher accuracy and lower bias compared to the ARIMA model. That's why they choose this model for this study. If we talk about the result section, so there are a few terminology that we need to understand. The first terminology is disability adjusted life years. So it's a measure that combines both the years of life lost due to premature death, that is YLL, and the years lived with the disability or illness, that is YLD. So the years of life lost is the number of years a person loses due to early death compared to the standard life expectancy. So the life expectancy in Pakistan is 65 to 70. So let's say it's 70. And if a person dies at 50 due to cardiovascular disease, the years of life lost will be 20 years. If we talk about the years lived with disability, so these are the number of years a person lives with disability or illness. So if a person has heart attack and he somehow survives it and lives for the next 10 years, so the person lives those 10 years with the reduced health. The combination of both years of life lost and years lived with the disability gives us disability adjusted life years. So it reflects the overall burden of disease by considering both fatal and non-fatal outcomes. The next terminology that we need to understand is ASMR, that is age standardized mortality rate. It is the measure used to compare mortality rates across populations with different age distributions. Let's try to understand this with an example, people and few young people because of low birth rate. So this makes an overall death rate higher since older people are more likely to die from cardiovascular disease and other health conditions. Without adjusting for age, it might look like Japan has very high death rate, but that's mostly because the population is older, not because the people are at high risk. So, age standardized mortality rate helps us by showing the real risk of death without being affected by age of the population. The next terminologies that we need to understand are the crude mortality rate and total crude mortality rate. Crude mortality rate, this is the number of deaths in a population during a specific time period per thousand or lakh people. So the population size is defined in the crude mortality rate. While in total crude mortality rate, this is the total number of deaths in a population over a given period without adjusting for the population in size. So it's simply a raw count of death, and it's an absolute count of death. If we talk about the result, this is an overview of the to 2050. The first graph represents the ASMR, and the ASMR is expected to be decreased by 23% by 2050. The decrease in the ASMR suggests that fewer people are dying from the cardiovascular disease on average per lakh in a standardized age structure. However, if we talk about the crude mortality rate, it is going to be increased by 91.2% from 2025 to 2050, amounting to 24.1 million deaths across Asia in 2050. By 2050, the prevalence of the cardiovascular disease will reach 729.5 million. This is alarmingly high. The top three cardiovascular disease that is going to prevail by 2050 are ischemic heart disease, peripheral artery disease, and stroke. The mortality rate will be high because of ischemic heart disease, stroke, and hypertensive heart disease. These will be the main cause of mortality in the future. So this graph represents the percentage change of ASMR between 2025 to 2050 among the main focus is South Asia because it includes the Pakistan. So in South Asia, the peripheral artery disease is predicted to have the largest rise in ASMR from 2025 to 2050, which is 59.2%, followed by atrial fibrillation and flutter, which is going to be 15.6%, and aortic aneurysm, 1.5%. The main risk factors are high BMI, high fasting plasma glucose level, and the non-optimal temperature. Overall, ischemic heart disease is the main cause of death in Asia, as we have discussed in the previous figure. But in South Asia, the leading cause of mortality is the peripheral artery disease. So this highlights the differences in the health issues across different regions. The main risk factor among different region is high BMI, except Central Asia, where high focus level is the main risk factor, will be the main risk factor. Um, these figures represent the data projected for 2050. So the figure represents the ASMR will be the main cause of mortality among different among almost all the regions except Central Asia, where high fasting plasma glucose level will be the main reason of mortality. And if we talk about the ischemic mortality rate due to cardiovascular risk factors, so the ischemic heart disease will be the main cause of among most of the regions except high income Asia Pacific, except Southeast Asia, where stroke is the main cause of the mortality. In figure B, they have described the disability adjusted life years. A high systolic blood pressure is the main reason of disability in most of the regions except Central Asia, where high fasting plasma glucose level will be the main cause of the mortality. And uh, ischemic heart disease will be the main cause of disability in most of the regions except high income Asia Pacific region and Southeast Asia, where stroke will be the main cause of disability by 2050. These figures represents the data of disability-adjusted life years and ASMR projected for 2050. In South Asia, we see disability-adjusted life years rate at 4,557, which indicates a significant burden of disease and disability in the region. Additionally, the mortality rate is 207 per lakh, pointing to the serious health challenges we face. When we compare these figures, the Central Asia shows the higher disability-adjusted life year and mortality rates, while the high-income Asia-Pacific region has the lowest rates. So these differences underscores the urgent need for ongoing investments in healthcare and disease prevention to improve health outcomes in South Asia. If we talk about the limitations of this study, so the primary data was collected from different regions, and each region utilized different evaluation methods and case definition, which may lead to potential inaccuracies when estimates are combined. The other limitation of this study is that the projections in this study rely on historical estimates up to 2019, excluding the impact of COVID-19, which is linked to increased cardiovascular risks. The Poisson regression model, which is utilized in this study, has some limitations, like it is prone to over-dispersion and assumes linear relationships that may not account for future changes in risk factors or other scenarios like climate change or geopolitical shifts. The main points of this article is that the cardiovascular mortality will be increased by 91.2% from 2025 to 2050. Aging and population growth will challenge the healthcare system in Asia. The Central Asia will see the worst cardiovascular disease, and the high-income Asia Pacific regions will see the least. Atherosclerotic disease and high systolic blood pressure will remain the leading cause of mortality due to cardiovascular diseases. That's all from my end. I appreciate your attention, and I will now hand it over to the Iman. Thank you.
Thank you so much, Zarhaish. You went over the article very comprehensively, and Zarhaish also explains some very important terminologies that you need to know before you are reading the results. So thank you so much, Zarhaish. It was very interesting to see the differences between different regions within Asia, which is something that I personally was not expecting. And from a statistical point of view, it was also interesting to see how they chose to apply the Poisson regression model instead of the ARIMA model, right? Because they first took data from 1990 to 2009, I believe, and then they trained the Poisson regression model based on that data, and then they first forecasted data from 2010 to 2019, and then they compared that with actual data from those years, and then that's how they chose the Poisson regression model. So it's not just about what is the most suitable model to apply in terms of statistics, but they took actual data and compared that and saw कि कौन से वाला बेहतर है in terms of forecasting data. So I think that's something very interesting. So before we begin, I would like to introduce our panelists for today. We are joined by Dr. Mariam, who is joining us from the US. She is an alumnus of FMH. She graduated in 2019 and she completed her house job in 2020. She was a very active member of the student body while she was here at FMH. She was the president of the Debate Society. She was also a member of the Sports and Dramatics Club. And she was the pioneer of the Humans of FMH Society and was also the president. She currently is a second-year resident in internal medicine in the US. And she will be joined by Dr. Zarrar, who serves as the head of the cardiology department here at FMH. He is known amongst students to be very student friendly and is engaged in a lot of activities with students. He organizes an ECG workshop every year, which students actively participate in, and also a BLS workshop that again students actively participate in. So first of all, I will hand over the mic to Dr. Mariam to share her insights on the article.
Assalamu alaikum, everyone. Thank you for always being very active on these journal clubs. I really appreciate the student-led things because these are some of the learning tools that you'll get from your medical school, and they'll take you a long way. And I really like the article, the way it was comprehensive about these all things. Having said that, the presenter presented it in very detail. I don't want to pronounce the name wrong. I think it's a very difficult name, Zarnash or Zarhash. Sorry, I don't want to say the wrong name. But
It's
he did
Zarhaish.
Zarhaish. Okay, sorry. Zarhaish did a very phenomenal job. Like it's easier to read the article, but it is difficult to interpret it. And the way the statistical tools and everything that were utilized were like, I would say, decoded in a very simpler way. They were very like nicely done, and kudos to the presenter. The other thing is that one thing that I was reading that was very interesting, the projection models are little bit tricky, as it was mentioned in the limitations also, because our region, which is like South Asia, Southeast Asian regions, and Asian population, we are like a very diverse population, I would say. Our ethnicities, our demographics, our gene pool is very much, I would say, diverse. That that entails like there could be different outcomes in the future than this one. The Also, one of the thing is that with the disease burden being increased, our average like age, the that is also decreasing of the years. That's been also mentioned in some of the recent researches. Like rather than 65, they say it's like late 50s. That's what the news researchers have been saying. And the interesting part was that I was reading. Not only I read this article, but I was reading about all the data that they have explored and the gathered data that they were talking about. So cardiovascular disease in South Asia, they gave the findings from 2022. Like they were saying like they have seen the data from 1990 to 2022, and they were saying that cardiovascular mortality decreased by 11.3%. That was like amazing. I was like, okay, so they were talking about those data that they have actually extrapolated from different regions in the South Asian region, and which was very interesting to know. But this, and also interesting to the way Zaresh mentioned that in South Asian region, we would not be having cardiovascular disease like ischemic heart disease being the biggest demon around, but it would be PAD. So that was interesting to find out from the study. I like the way they extrapolated these things, but Dr. Zarrar is more, I would say, expert in his field, and he would be able to entertain about what he sees more in his patients. And because our Pakistani population, the thing that we always struggle is that our data is never being given in the real times, and we do not have a standardized body where we could have the data being exported. So that sometimes masks the real disease burden. But having said that, all these studies and even the small studies, even if you guys, after reading this article, have a small RQI project where you want to decrease the disease burden and want to see what tools you can use to decrease the disease burden, that would be interesting to explore as a student. And I think that would be a good way to go about. But having said that, these all articles and all these educational points that you read in or they're being discussed in a journal club, you also need to see in your real time also, like scenarios where you meet the patients and like that, and see how the risk factors can be modifiable. There will be some risk factors for your patient which you can't modify, but there will be like their age, their ethnicity, these things you can't. But the risk factors like their diabetic control and like that, small things needs to be changed in the daily like living of the patient that could create a lot of impact in their lives. Thank you.
Thank you, Dr. Mariam. Dr. Zarrar, I would like you to share your insights now.
Thank you very much. I hope everybody can hear me.
Yes, we can.
Okay, perfect. So first of all, I would like to congratulate Dr. Zarhaish on a very well presented paper. I think she's from third year, if I'm correct.
Yes, she's from third year.
Oh, so being in third year and having a comprehension of this kind of a paper and the in-depth analysis that she presented, I think she deserves a round of applause. So that was very well presented. She actually took the gist of the paper and highlighted the proper areas which needed uh, highlightement and discussion. So she left you with certain terms that obviously the bunch will remember and can work on them. So wonderful job, Zarhaish and Zarhaish, sorry. And I think it's heart gives me a lot of heart seeing the students, coming forward because believe you me, at our time we had a very minimal idea of what a research paper was and how to read it out and how to take the gist out of it. So wonderful, wonderful job. And remember, this is now the era of evidence-based medicine. So research papers and being part of research papers and being part of the journal clubs, it is a wonderful thing. So a round of applause for Zarhaish. Secondly, I would like to congratulate the moderator to round up this event. It's a wonderful activity and it's a proper utilization of technology because everybody's short of time. So using Zoom for such a journal meeting and then getting such an interesting paper to come forward, I think wonderful job for the for those of you who have worked this out. Thirdly, it's wonderful to have to see one of your students doing so well. Mariam, I'm very proud to see you doing so well in the States. I hope
Thank you so much, sir.
uh, uh, in which state are you currently?
I'm in North Carolina. I am internal medicine and pediatrics combined,
Oh,
resident at
so
East Carolina University.
okay. So do you live in Raleigh or somewhere else?
I live nearby Raleigh. It's Greenville. There's
So,
yeah, and you yeah.
one of my class fellows is actually there. I think you may know an internal medicine from consultant from Pakistan, Dr. Nawaz Shima. Is he there?
I'm not sure, but I can find it out. If he's in
Uh,
Raleigh,
eh, no, he's not in
I can
Raleigh. He's
find
in
it.
North, and he's in North Carolina. So
Okay,
I'll find it out. So if the moderator can share your, contact with me, I'll definitely find it
sure.
out. And one of my very close friend is a nephrologist there. Although he runs his own group, I don't think so. He's in the hospital, Dr. Noman Shahid.
Is
So
I
he's
know
in
Dr.
there.
Naman Shahed. I know
Oh,
Dr. Naman Shahed.
Noman is my class fellow. Sabine is my class fellow. You must be knowing Sabine as well, then his wife.
Yeah, yeah. I know
So,
them. I
so,
know them.
so, so when you meet them, do pass them my regards. I'm sure they'll take good care of you as well because they're a very good
Thank you.
bunch of people
Thank
and
you.
they do round up Pakistani population there and
Yeah.
have a good chat. So this is just offhand. So, so,
Thank you
so
so much.
please do share your contact with me or the moderator can share your contact with me. So I would like to stay
Thank
in
you.
touch with you. So,
Sorry. It's so thank you so much, sir. Thank you.
oh, my pleasure, Vita, my pleasure. And one more thing, I'll take advantage before I turn to the paper because we had a very good discussion, and I don't want to. I know these things are time bound. So, I've been appointed as a member of alumni, coordinator. I'm already a house officer coordinator. So the next task I'm being given is being a coordinator for the alumni. So do stay in touch because we are trying to get everyone registered. And just like these activities that the students have carried out, we would like to see more of these activities using you guys who are abroad as alumni because I'm sure there must be some positives and negatives that you took out of Fatma Memorial. But at the end of the day, this is your college and you guys need to, represent that all
Yeah,
around the
and
world.
I have tried my best to be in contact with the other upcoming class like Iman's class and everyone's and the CHSR the CHRS this forum was started from the alumni. I was one of the leaders initially starting this thing. along with other people,
So
Dr.
you are
Hamad.
already so you're already
Yeah,
doing a great job. So now we just want to streamline things so that we can appreciate people like you who are already raising the flag of Atma Memorial all over the world. But we want to highlight your activities on a specialized web page and all that. So please do keep in
th-
touch with me, and I'll get your
thank you, sir.
contacts in future.
Thank you, sir. Thank you.
Now, coming to the paper, which Zarhaish has so well presented. Now, this is actually an eye opener. You know, when you're talking about cardiovascular disease, for few, a couple of decades back, you would have considered that cardiovascular disease is a disease of the rich countries, the Europe and American countries, the Middle Eastern and those countries who are very rich and they rarely walk around and do stuff on their own. The Southeast Asian and South Asian population was considered to be a very healthy population because they worked around, they ran around, they did stuff on their own. But since the couple of decades have passed on, so since probably the start of the millennia, so the things have rather evened out, and now it's not the disease of the poor anymore, and the numbers suggest so. And these numbers that we are seeing now, the projected number for 2050, they are just like a Halloween, coming early, or probably at this time, Mariam probably will be having Halloween parties going on around. So these are probably an eye opener for us because it is almost 100% increment. 91% is almost considered should supposedly 100% because when we talk about these numbers, usually the data collected from the South Asian countries, especially India, Pakistan, Bangladesh, Sri Lanka, it's always a bit scanty. The real data is somewhere underneath all the piles. So we only get the surface data, as we say, the iceberg lies beneath. So I would think that there must be 100% increment of the disease by 2050. So that shows that there will be a huge burden of cardiovascular disease patient, which will be not only just a burden on economies of these poor countries who are already suffering from poverty and whatnot, and who already lack the basic health facilities and whatnot, but because you have seen Delhi and you have seen, the morbidity of repeatedly hospitalization, and so these people will be coming back to the hospitals, and they will put more burden on the healthcare system. So will the healthcare systems of these poor countries will be geared up to take up such a burden? I think a collapse would be something that we might see unless we do something about it. So the actual advantage of getting these numbers is that we can plan and do something about it, especially those people who are at a higher level or at decision making level. So there are a couple of things that are highlighted in this paper, especially if you're talking about South Asia. Comparatively, we are still not doing that bad because the incremental or aggregated increment that I've seen in percentile is probably around 50 to 60%, while Central Asian countries like China or maybe Japan or something like that, or maybe the more of the near to the European Turkey, etc., they have sporadic numbers. They have up to even 102% increment I've seen through this paper. So we might still be doing a bit better from others, but still, the number of population that lies in South Asia, the that makes it an exponential increment in the number of patients altogether, even being the percentile comparative to the Central Asian population a bit less. Another thing that this paper has highlighted that we need to consider seriously on working on hypertensive management because that is supposed to convert for our part of the world, convert more of the patients into ischemic heart patients. For the Central Asian countries, yes, it's the diabetes and the central obesity, but for our part of the world, it's hypertension actually. And I think why it's very common in our part of the world because of the level of high stress, because poverty and trying to make both ends meet, there is a high stress level. Then our diets, there it's a lot of spices. So the subcontinent of Pakistan, Indo-Pak subcontinent is actually the subcontinent which was introduced to the world because of its spices. and the Britishers came here for primarily to indulge into these spices. So our food have such a high salt contents and spices that probably tilts us towards getting higher blood pressure. And last but not the least, I think after the new era of millennials, as they call you guys, or Gen Zs now, as they call you guys, is that there is too much limitation of actual, physical activity because of the tabs and mobiles and AIs and whatnot available now. So people are more, facing screen, having screen time, and less having, outdoor times and less of the physical activity. So in turn, I think that is another push that is giving, that is, dragging us towards this horrendous number of increment in the ischemic heart disease patients. So I think this paper that was very well presented by Zarhaish is actually an eye opener, and I think this is the time that we all need to consider our options and how can we, because if we lose this time, um, as the time passes very quickly, so we might not be able to grasp this increment and might not able to do something about it, especially with limited health services and with the ischemic heart disease treatment being so expensive, like primary TCIs and whatnot. So I think this is the time that we need to sit down, not just as a nation, but as a South Asian continent, and decide what to do and how to make our people more physically active, less utilizing the salt, and improving our lifestyles, because that will in turn probably help us in long term. So this is my 2 cents on this paper. Hopefully it was some help to everybody.
Thank you, Dr. Zarar. So one thing that I wanted to discuss was, how our lifestyles, especially our diet in Pakistan, it's not very helpful in terms of, developing cardiovascular diseases. So the patients that you see in the clinic every day, do you think that after developing CVD, are they willing to change their lifestyles? Are they willing to change their diets? Or is that something that they just continue doing?
So Iman, the thing is that we usually get patients, especially from the higher ages group, telling us that we used to eat a lot and our forefathers used to eat a lot, and then I have keep on reminding them that at the time of our forefathers, who used to eat a lot of ghee and a lot of red meat, and still were not having such a heart disease because they used their legs a lot. They were not taking off their bum from one seat to another, from one picking up their from an office seat to a car seat and then back to a couch at home. So they used to travel a lot by using means by traveling, just walking from one place to another, or maybe cycling around a lot. So, and the physical activity that they used to perform was probably 100 times more than we do now. So yes, we have to counsel the patients regarding what is lifestyle modification, because if you Mariam would agree with me, she's in States, and evidence-based medicine is practiced there, and we at Fatma Mural also uh, practice evidence-based medicine. So treatment of ischemic heart disease or hypertension or stroke, which are cardiovascular diseases in the whole, starts with lifestyle modification. So that's the first line treatment, as they say. So because Mariam has already mentioned some modifiable risk and non-modifiable risk. So we cannot do something about the non-modifiable risk, but we do need to modify our lifestyle and address those modifiable risks if we want to treat the patient. And the counseling is very important. Yes, the patient do take some time to understand what we are talking about, but when we give them the advantage that if you want to keep your prescription down, if you want to keep me from writing, a lot of numbers of medications on your prescription, then you have to put your bid in it. So what I tell my patients that this is kind of a committee that we are putting it together. So either I can put in more share, or you can put in more share, but the advantage will be all yours. So if you put in more share, my share will be less as a doctor. So I will have to write less medication on your prescription paper. So that is how I counsel my patients that, if you are ready to do your bid, then my bid will be limited to shrink down, and that would be to your advantage. You have to take lesser medication in long term.
Thank you so much, Dr. Zarrar. Dr. Mariam, would you like to add anything before we conclude?
No, I just want to motivate everyone. Thank you so much, Dr. Zara. It was very insightful from your perspective and because you see patient day-to-day life. And the other thing is that I just want to say that just have an inquisitive mind, and also from these papers, whenever you read any other paper or anything, you want to compare and contrast something, you can just see the vascular studies done in America. American Heart Association have good articles upon those things too. And the other new guidelines, if you want to see those things, you can. But I want also encourage the students to develop some QI projects to help to see how those things are run in day-to-day life. That would be a new thing that I want you guys to be introduced to. Maybe you might be doing it before also, but if you need any help for like mentorship or like that, I'm available for that. Thank you.
Thank
Can
you
I
so much.
can I add one more thing? By taking advantage of Mariam being here, uh, I am actually trying to pilot a research project here as well. So what we are planning to do is we are planning to get blood pressures of the students from first year to final year. We are trying to get some randomization, and we are trying to work something out so that they can either get their own BBB apparatuses, which might some of them or most of them might already have at their home, and we may split them with the other data by collecting ambulatory blood pressure monitoring that we have now in our department. So you being in America, you must have seen those Framingham studies that are being carried out and ongoing processes of adding up numbers in hypertension. So that is what we are planning to do. And any of the students who are in this group who want to be part of it, I would love to make them a member of those data collecting participants. So we are hoping that we'll get data from the young population of Pakistan, and we can compare it to the world, and we'll see where the average blood pressures of our young students who are between somewhere 19 and 25. So we need to compare their data with the world, and we'll come up whether as per new AHA guidelines, where do we stand. So this is another thing that we are having a pilot, we are having in a pipeline.
Thank you so much for sharing that, Dr. Zarrar. It sounds like a very interesting project. And thank you for joining us today, both Dr. Zarrar and Dr. Mariam. Thank you for taking out time from your busy schedules. And to all the participants who joined us today, thank you so much for joining another session of CHSR. And we'll hopefully see you in the near future as well, inshallah. Thank you. And that is the end for today. Allah Hafiz.
Thank you for having us. It was wonderful.